Hello, everyone. I'm Dr. Lisa Nijm, founder of MD Negotiation and Real World Ophthalmology, CEO of Women in Ophthalmology, founder and medical director at Warrenville Eye Care and LASIK, and assistant clinical professor of ophthalmology at the University of Illinois Eye and Ear Infirmary. And I am absolutely delighted to be joined by my dear friend and colleague, Dr. Anna Carolina Victoria, who is chief of oculoplastic surgery at the Center for Excellence in Eye Care in beautiful Miami, Florida. Welcome, Anna Carolina.
Thank you, Lisa. It's so good to share the stage with you yet once again.
Yes, I am absolutely delighted because you guys are in for an incredible conversation. I always learn so much from Anna Carolina, and we're going to be going over the most frequently asked questions about the management of thyroid eye disease. So, we're going to jump right in. What are some of the benefits and challenges that steroids and biologic agents present for clinicians in terms of safety and efficacy for thyroid eye disease? We've heard about that. I mean, that's been kind of the mainstay of treatment from the beginning. Many of my patients have been the recipients of steroids and some of these biologics. What is your, um, what do you feel are some of the benefits and challenges of them?
If you ask anybody, and literally anybody, and you give them just 1 or 2 doses of steroids, they love them, right? I mean, they take care of aches and pains. Your swelling goes away super quickly, but just as good as they are acutely, they're not so good chronically, right? And they're not disease specific. They're not targeted therapies, and they have a lot of side effects, and you don't know how they're going to affect you until you've been on them. So steroids are great for the most part to get you out of trouble. But for the long term, you really can't keep these patients on steroids. And as I said, it's really not targeted therapy. Okay. So they're my friend in certain occasions. When it comes to biologic agents, before we had targeted therapy, biologic agents were really kind of second class citizens. They were there and we used them because there was really nothing else we could use. We were just kind of throwing something out there to alter their immune system to figure out how we could kind of quiet down thyroid eye disease. And so, all of these agents come with side effects that may be potentially worse than the disease. And so, you have to take every treatment that you offer a patient with a grain of salt and talk about the risk benefit alternative of treatments that are not necessarily tailored for what you're treating, but rather are more broad in their sense of how they affect the human body.
I think that's a great way to think about it because oftentimes, we need something that's fast acting, and so turning to steroids makes sense. But it is, especially in higher doses, oh my goodness, it really takes the toll on the patient. And from everything from weight gain, I've had patients who've had problems with weight gain and psychotic episodes. And like you said, like for the first day or two, it's really good, but then the reality sets in that these are actually really strong medications that we're applying broadly for a very specific disease. So that brings me to the next question. So the alternative then, or one of the alternatives, is to use radiation. So at one point, do you recommend for patients to use radiation, and how is it administered?
Radiation, when you talk to patients about it, or when they hear that word, they get really scared, right? Radiation means you're potentially causing a lot of secondary effects as well. And when they think of radiation, they think of potentially cancer, right? That's when you're used to hearing that word. So radiation, it is our friend in certain instances. I think radiation is great for patients that have more muscle than fat involvement in their thyroid orbitopathy or thyroid eye disease. I don't use it as a first line agent. I use it as a friend that holds hands with my steroids. So if I have a patient that I think is really acutely inflamed and I can't use targeted therapy, or I can't get my hands on the targeted therapy until later and I need to get them out of the woods, I'll start them on steroids, see how they respond. And if I see that they're not responding enough, I can always add radiation, especially as I said, if they have more of a burden in their extraocular muscles. It's really great for thickened muscles. And the beauty of using it with steroids is that radiation can cause some inflammation while you're applying the radiation to the orbit. And so while the patients are on steroids, it's a great time to do it because they're already treating for the inflammation with the steroids. And so I do use radiation. And then your follow-up question of how is it administered? It's actually a pretty low dose of radiation that we treat the patients with. It's a total of 20 gray. And the typical dose regimen is to treat for 10 doses total, 2 gray per dose. So usually you do 2 grays, for 5 days times 2 weeks. So you're basically getting radiation every day of the week for 2 weeks.
It is wonderful to have multiple options to treat patients, and certainly we see patients at all different levels of involvement of their thyroid eye disease and the need for various treatments. I'll tell you what pulled me into thyroid eye disease goes to this next question that we received, and that's in regard to teprotumumab. To me and many others, teprotumumab was a game changer for thyroid eye patients, and I think something that has completely caused a paradigm shift in how effective our treatments can be for thyroid eye disease. So, you are my expert here. What are the indications for using teprotumumab?
First came out and was indicated for acute high activity clinical activity score patients. And as this disease continues to have more research in the field, we've realized that even patients that are chronic, not high clinical activity score, will respond to teprotumumab. So officially, really, the indications are for anybody that has thyroid eye disease, regardless of activity, regardless of chronicity or acuity of the disease. Now, with that being said, again, you have to weigh in. If a patient really only has dry eyes as their symptoms, you have to weigh in the risks or benefits and alternatives. And I'm a huge proponent of this, of really taking any kind of medication that may have side effects that are worse than what your disease has. But for all intents and purposes, on label is for any patient that has thyroid eye disease, regardless of clinical chronicity.
Yeah, I couldn't agree more, and I think, this is why I like working with you. You put the patient first and discussing those risk benefits and alternatives of any therapy, this is also the MD/JD side of me coming out, is incredibly important, not only in the evaluation of treatment, but also in documentation of the disease and what you offer them. Just like teprotumumab is not for everybody, but neither are some of the other treatments. And so identifying what the best treatment is for that patient at that time and being having all the options available, I think can really make a difference to helping some of these patients, especially those now that we know there's treatment, there's improvement for chronic disease, chronic patients who are typically considered chronic thyroid eye patients. I think this has been a real breakthrough with it. How long does teprotumumab last?
So it's a great question. And I think studies, again, this is a recently developed medication, and we're learning more and more about it as we go. And we know that it's an antibody, right? So antibodies are being infused through the patient's system to kind of blanket the targeted tissue, right? The orbital tissue on the IGF-1R receptor. Once that you stop that infusion, the antibodies are officially out of your body in 3 weeks or so, maybe 6 weeks or so. However, the effect of Tepro lasts several months and potentially years, and potentially the patient may never need to be treated again. It really depends on each patient and their disease state and how inflammatory what their immune system is doing against their IGF-1Rs, really, right? So it really is very patient dependent. There's current literature that shows that it's, somewhere around 20-30% of patients may relapse or flare up. Is it really a flare, or is it just that we were blanketing the tissue so well that once we take off that antibody, the immune system just kind of, attacks it again because we took off that antibody. So because it's such a heterogeneous disease, because each patient presents so differently and their disease progress and their journey is so different, we don't know how long it lasts in each patient. We can say that in average, my patients, the ones I've had to retreat or that have flared up, usually I'll treat again in an average a year and a half. But patients will need to get retreated sometimes at the 6 month or 9 month mark. It's very hard to know who will flare up and when they'll flare up or need treatment again.
I think that's what's so important about having someone like you, an expert on the team who has familiarity with teprotumumab, to be able to tailor the treatment to the patient and to their particular disease, as you so aptly described. It is a heterogeneous disease and not necessarily one size fits all. So, watching for signs and symptoms of recurrence and having all the tools in the toolkit to be able to treat it should that occur, I think is critically important. How many times can we repeat the treatment then with Tepro?
Great question. I don't think that there's a finite number of infusers you could do with Tepro, right? And I think again, we're learning from our patients as we go with this disease and with this treatment, there's no finite number. Right, it's an antibody. It doesn't live in your system forever. We also know that this antibody attaches to any IGF-1R receptor, and we know that it can cause side effects. So you always have to keep that side effect profile in mind and keep monitoring them if they do have side effects. And maybe you don't want to repeat the treatment if they develop a higher risk profile. So again, it is all about patient tailoring and keeping in mind that even a second or third infusion may develop a side effect that didn't happen the first time around.
So I think that's a great segue to the next portion of our discussion. Because would you discontinue or delay Tepro infusions if side effects like hearing loss or increased blood sugar occur?
Great question. And you just said in a recent podcast, you're the quarterback for your patients, right? And I feel that way for mine as well, because risk benefit alternative profile discussions are like literally it's my mainstay discussions with this patient, and having the team set up for any of the side effects and the main side effects that we can encounter is so important. So ENT, I have my patient set up with an ENT before they even start on Tepro. I have the patient follow up with their endocrinologist before they're on Tepro, because I'm not an audiologist. I'm not an ENT. I'm not at liberty to tell the patient, continue on if I see that the audiology has changed. I have an ENT that will guide us through the process and speak to that patient and tell them, look, this is what's going on. This is what we should or should not do. And that can communicate with me the same reasoning of whether or not we should pause or repeat audiology and do the infusion. And that's why that team of care is so important for the patient, because it's not a one size fit all. Everybody will have a different profile of side effects.
I completely agree. And I think that's one of the most important things in making sure that our TED patients have the best care is, identifying who those people are going to be on your care team, your ENT, your endocrine, oculoplastics, your comprehensive ophthalmologist, or your cornea specialist, whoever, those people are going to be involved so that they can help in making the decisions that are going to be best to determine whether it's appropriate to continue forward or delay treatment should any of these side effects occur. I know that there were some questions about Tepro potentially leading to structural changes in the eye muscles that can cause a challenge in subsequent strabismus surgery. What's been your experience with that?
In general, when patients have undergone teprotumumab for their thyroid eye disease and then subsequently need extraocular muscle surgery, the surgeons are actually so pleased with how the muscles react and behave when they've been on Tepro versus the muscles of patients that have not been treated on Tepro. And I think this again has to do with the protective effect of that antibody, right? That blanketing, that caring for that tissue that's being attacked while the disease process is going. And so when they have to operate on that muscle, it's a more normal muscle than a muscle that's been attacked and inflamed and is now fibrotic and tight. So I guess the question was, does it lead to structural changes? I think the answer is it protects the muscle from undergoing structural changes.
I think that's really important because one of the long-term effects of this is, really changes in people's appearance and their, the structure of their face and how they don't feel like themselves. We've all heard and had patients like that. So I think this is part of what becomes really important in helping patients to regain their confidence and regain their normal appearance, and whatever we can do to help maintain that and help address those aspects of the disease. It may not prevent them from having surgery, but hopefully will help them get the best results from surgery.
Yeah, I couldn't agree more.
These have been amazing questions. I want to thank you so much, Dr. Victoria, for sharing your knowledge and for this excellent discussion. And thank you, everyone, for listening. Please remember to take the post test and evaluation to receive CME credit and tune in for additional episodes within this podcast series. Thanks so much.